So the Beat AML Master Trial is actually a consortium of academic centers all around the United States. And our goal is to bring novel therapies to a population of patients that don't have great outcomes when they're diagnosed with AML. And so that is our elderly population over the age of 60. We know that they don't do well with intensive chemotherapy because they tend to have biologically resistant and aggressive disease, and also because their organ function and their comorbidities preclude intensive chemo. So in kind of as a bird's eye overview, the master trial enrolls elderly patients that are unfit for chemo and does rapid next generation sequencing on them. And we do a panel of myeloid mutations that comes back in about 7 days. And in the past, we've shown that this is very feasible, that the dogma of finding an AML and treating right away is actually one that can be challenged, and it's safer to do this rapid sequencing and get a better idea of the mutational landscape and then make a treatment decision based on that. So what the Beat AML Master Trial does is it rapidly sequences all the mutations that are present in a patient's AML. And then we have novel therapies that we can offer for different targets. So if a patient has a target for which there's a therapy, either a doublet or a triplet, we would enroll them onto a sub-protocol. And if they are marker negative, meaning they have no cytogenetic abnormalities or no mutations for which we have a targeted therapy, they go into a marker negative arm. So this particular study was a sub-study, it's called S16, reported the outcomes of patients that had an IDH-R132 mutation. And it included 17 patients that had the IDH-R132 mutation, and they were enrolled onto a study that included Vidaza for 7 days, along with Ivosidenib at 500 milligrams daily continuous. And at the end of 6 cycles, if they were in a CR, then they were allowed to move on to another 6 cycles of Azacitidine plus Ivosidenib, followed by maintenance Ivosidenib indefinitely. And one of the great things about this study is that we know that these IDH inhibitors don't always yield a response right away. So one of the things that we had is if people were not in a complete remission at 6 months, they had some kind of clinical benefit, like they were transfusion independent or their blood counts were better, they were allowed to move forward with another 6 months of therapy and then on to maintenance. The only people that were taken off of study at the 6-month mark were those that had no clinical benefit and had progression or stable disease. And we saw that at the 6-month mark, which was our primary endpoint, seeing what the CR rate was at 6 months, it was actually around 82%. And there were 2 patients that got their best response after the primary endpoint, which happened months later. But if you include those 2 patients out of those in that population, the overall response rate or best overall response rate was close to 94%, which is pretty amazing. Studies like that or results like that are rare to come by in patients with a high-risk AML that can't get treated with intensive chemotherapy. So that was the most exciting thing about it. So the study was actually terminated per sponsor decision in 2019, but I think that was because other phase 2 trials showed equally good responses with the same therapy. And actually back in August of 2021, the phase 3 AGILE study, which was Azacitidine plus Ivosidenib, was terminated because the response rates looked so good and the results were so good. So I think in terms of just this doublet therapy, we've found a good combination that's going to be used. And I think the focus and all the energy for these clinical trials now are going to go towards finding a group of patients that are known to be resistant. So we know co-occurring mutations and in pathways like the RAS pathway tends to be resistant to IDH inhibitor therapy. So now research is going towards what kind of novel agents are being used to treat patients that we know upfront are going to be resistant to these therapies. And the other big thing is sequencing of these therapies. We know that venetoclax azacitidine is also equally successful in these IDH inhibitor or IDH mutated patients, and trying to figure out, is it better to give triplet therapy with venetoclax and the IDH inhibitors, or is it better to sequence, is where I think a lot of the new data is going to come out.